Good afternoon. Thank you for the opportunity to present our work entitled Incisional Hernia Repair in Patients with a History of Solid Organ Transplantation. Dr. Paulos has research support from Advanced Medical Solutions and salary support from Abdominal Core Health Quality Collaborative. Solid organ transplantation saves many lives in the United States and around the world each year. The frequency of these operations and the long-term survival of the grafts continues to increase with improvements in technical skills, post-operative protocols, and immunosuppression regimens. This has resulted in a total of 80,000 patients alive with a functioning graft today. Retrospective studies have estimated that the rate of incisional hernia after solid organ transplantation ranges from 4 to 34%. This means that an estimated 3,200 to 27,000 patients are alive with incisional hernia at this time. This is a large patient population at risk of everything from lifestyle limitation to more serious consequence, bowel incarceration at any given time. Previous studies have shown that risk factors for the development of an incisional hernia after transplant mirror contributors in the general population. These include reopening recent laparotomy, acute rejection episodes with a steroid bolus, thrombocytopenia, transverse abdominal incision with an upper midline extension, advanced age, and a high BMI. Due to the high prevalence of ventral hernias in patients with a history of solid organ transplantation, we wanted to investigate the outcomes of incisional hernia repair in this patient population to determine if special considerations need to be made when evaluating them for repair. The aim of the study was to determine if having a history of previous solid organ transplantation imparted an increased in-hospital length of stay after incisional hernia repair. Secondary outcomes included wound events. These included surgical site infections, surgical site occurrences, and surgical site occurrences requiring procedural intervention, as well as any complications 30 days after the operation. The data for the study originated from the Abdominal Core Health Quality Collaborative. We selected hernia patients greater than 18 years old who underwent elective incisional hernia repair from the years 2013 to 2019. We excluded ostomy and peristomal hernia repairs. After removal of those without appropriate follow-up data, we had 165 patients with a history of solid organ transplantation and 13,452 patients without a history of solid organ transplantation. Patients with a history of solid organ transplantation and those without were compared. Frequencies and percentages were compared with chi-squared and the Fisher's exact test. Continuous variables were compared via two-sample t-test and Wilcoxian rank sum. This was followed by generalized linear regression with a binomial model, which was utilized to compare the length of stay between transplant and non-transplant patients. Results were adjusted for nicotine use, age, gender, BMI, hernia width, and recurrent hernia repair and type of hernia repair. Our population is as follows in this chart. So a pretty even distribution between males at 44% and females at 55%. The average age was about 58 years old. The ventral hernia approaches included open, laparoscopic, and robotic, as well as laparoscopic assisted and robotic assisted. Comorbid conditions, the most common by far was diabetes, with 52% of the patient population recording a history of diabetes. Hypertension, COPD, dialysis dependence, and inflammatory bowel disease were also included. The results show that the length of stay among those with no history of transplant was 4.4 days, and those with a history of solid organ transplantation was 4.1 days. This was seen to be statistically significant with a p-value of less than 0.001. There were no significant differences in SSI, SSO, or SSOPI. However, after adjustment, there was seen to be no significant difference between the length of stay in the patients with or without the history of solid organ transplantation. The regression included adjustment for a few key considerations. One of these was a surgical approach. The results show that patients who undergo laparoscopic surgery have a 41% shorter length of stay than those who undergo an open approach. Similarly, patients who undergo a robotic surgery also have an associated 48% shorter length of stay than the patients who undergo an open operation. Further adjustment was completed to account for various patient characteristics. A few additional considerations emerge. Length of stay increased by approximately 1% for every year increase in age, and length of stay also increased by 5% for every additional centimeter increase in hernia width. And finally, length of stay increased by 2% for every kilogram over meter squared increase in BMI. And finally, patients without nicotine use have a 7% lower length of stay than the patients with nicotine use. Our data demonstrates previously described associations with increasing length of stay, with increasing obesity, age, hernia width, and with nicotine use. Our results demonstrate that transplant patients are similar to other patients with a history of open abdominal surgery. They have no increase in their hospital length of stay and no increased rates of SSO, SSI, or SSOPI when compared to the general surgery population. For these reasons, surgeons should consider them optimal candidates for surgical repair, and they should undergo the same evaluation for elective hernia repair and same preparations for surgery. Most importantly, their history of organ transplantation does not preclude them from receiving an elective hernia repair. Thank you for your attention and the opportunity to present our work.